For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 13 of Surfing the NASH Tsunami, our discussion of the value of community fatty liver screening starts now.
This week on Surfing the NASH Tsunami.
It's unable, because we don't know what the impact downstream of the test is, to provide any of that information that would be so valuable in terms of determining lifetime cost effectiveness. And it remains a gap in our communal knowledge about the impact of test and treat strategies for liver disease in general, not just for NAFLD.
This document is being proposed now with no discussion of how COVID could affect the diagnostics for liver. It won't be reviewed for 3 years. So therefore, we would be without FibroScan in the UK and in a lot of other countries that look at knives and they deliver a suggestion or a guidance for over 3 years while we're actually building back from a pandemic. I agree with a lot of what's in the document for good reasons, but I would like to see this now being done in conjunction with a pandemic and given draft approval for figures to look and collect all of this data that they want and ask, but also to help fight back better.
There's good evidence, or there's good rationale to support that if you inform a patient that manifests in primary care, you identify a patient in primary care with advanced disease stages, you have more opportunity to prevent, potentially treat in the future. So from that perspective, I strongly support this type of testing to be implemented early and be able to provide some preventive measures.
When we look at what costs we get back, when we look at that in terms of how many cases of liver cancer would we prevent, how many liver transplants are prevented, how many fewer decompensated cirrhosis cases are there, because these are the costly end stages of disease. But another important component of that is to look at disability-adjusted life years or quality-adjusted life years, and these are the indirect costs. How much lost economic output, how much lost work productivity. And when we think about therapeutics or interventions, it's not just liver disease. If we're addressing NASH, we're also going to reduce costs associated with other facets of metabolic syndrome. So we're going to have reduced costs potentially for hypertension, reduced costs of managing dyslipidemia and diabetes. So it's kind of a multifaceted approach.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guests, hepatology researchers and key opinion leaders Drs. Jörn Schattenberg and Ian Rowe, and Center for Disease Analysis Foundation epidemiologist and modeler Chris Estes, as they discuss building a case for community-based fatty liver disease screening. This week on Surfing the NASH Tsunami.
Boy, it's been a heck of a week in the world. I think a tough week, a sad week, a week for lots of reflection. I want to talk briefly about two specific things that have happened in the past week. This week began with the passing of Paul Farmer. I don't know how many of you are familiar with Paul Farmer, either directly through his work in epidemiology and infectious disease or in public health, where he has advocated for the idea and proven that you could build world-class health facilities anywhere in the world, Haiti and Rwanda being two examples, or whether you've read Tracy Kidder's books popularizing some of his work. But he was truly a unique guy with a unique belief set and a unique passion and optimism unlike anything I've ever read. And at 62, he passed away suddenly in Rwanda from, I believe, cardiac arrest. Way too young. Way too young. And that's a real loss for the world and a tough way to start the week. Of course, we ended this week with the war in Ukraine, another horrific event. And as we record this episode, the Ukrainians are making a heroic stand in the major cities. We don't know how it'll come out, but we can only hope for the best. And thank Europe on coming together, congratulate the U.S. on helping to get everyone behind the same sanctions, President Biden on helping everyone to get behind the same sanctions, and hope that this comes out well for democracies and for advocates of freedom around the world. With that, let me shift to the podcast for today. One of our interests since we got started here has been to extend awareness and screening in a way that advances patient wellness rather than simply avoiding patient illness. Louise has been articulate for only, at this point, about 109 episodes since she missed the first 3 in how important she views wellness as being, and Donna Cryer and others who've come on the podcast repeatedly have made the same point. This is an episode about wellness and illness and about the complexity of NASH. One of the things I talk about a lot is, because I'm old, I guess, or American, or both, is that I remember in 1969 1969 when Richard Nixon announced that he was going to start the war on cancer. And at that point in time, we believed there was a thing called cancer and there was a way to treat it. Over time, of course, we've learned that there is not one thing called cancer, that every cancer is different. And the fact that cancer appears on a body part doesn't mean it's the same cancer as somebody else's. Over time, I think we're starting to learn the same things about NASH through the various omics and through the other ways that we've done research and things we've learned about drugs, that NASH is not a simple disease where you get a NASH score and a fibrosis score, but many different manifestations and many different ways of getting there with two common outcomes. And even within that, two diseases. So specifically, F4 cirrhosis is a liver disease. It portends serious, fairly short-term liver morbidities, increases in HCC and transplantation and death, and requires aggressive attention from hepatologists. We probably don't have enough hepatologists anywhere in the world to treat everybody with F2 and F3, certainly not F1. But those earlier stages of fibrosis are part of a metabolic syndrome that encompasses diabetes, obesity, cardiovascular disease, probably a few other things. One of the problems is that it's easy to measure glycohemoglobin, it's easy to measure BMI, there are easy measures for cardiovascular. There are no clear and easy measures for fatty liver disease. But the idea that the liver serves as the energy regulator and manager for the whole body means that its impact is almost certainly far greater than what we can measure today. And again, certainly, more than simply an after effect of obesity or a knock-on from diabetes. And even earlier than that, simple presence of fatty liver was demonstrated to predict outcomes in patients with COVID-19. That and the pancreas being the only two organs shown to be able to do so. That's not that COVID-19 affected the liver, it's that how much fatty liver you had affected your response to COVID-19. So against that backdrop, we have NICE issuing a month ago draft guidance on the use of FibroScan in community settings in the UK. Now, the comment period runs through March 9th, and we're going to be talking about this episode. But the key conclusion in the draft guidance is, and I'm going to read this, using FibroScan to assess liver fibrosis or cirrhosis for adults in primary or community care has potential to provide significant patient and healthcare system benefits. However, there is not enough certainty to recommend it as a clinically effective and cost-saving option for routine use. They then go on to talk about the need to do more research on where that might go. What we've done today is to convene a group of people who collectively, I think, are really well equipped to explore that full statement and the recommendation from different perspectives and talk about what it means, what it tells us, and what other ways NICE might want to think about things in the statement. So obviously one is Louise. This is her passion, and Tawas in Health. Her company actually provides community FibroScan services in the UK, and as a result is certainly directly affected by what comes out of this whole discussion. Second, we have Jörn Schattenberg with us today. Hey, Jörn, how are you today?
Hi, Roger. Thanks, I'm fine. A little shaken by the events that you mentioned in the beginning, but otherwise just came home from a short vacation and looking forward to this discussion today.
Thanks, Jörn. Jörn, as everybody who listens to the podcast knows, based on his fifth Beatles status, is capable of being a fantastic discussant on a bunch of things. But recently, we discussed a paper that he and colleagues published in Germany, taking a look at prevalence in the population there based on blood tests. Third, we have Ian Rowe with us today. Ian, how are you?
Very good, thank you, Roger. Pleased to be here again.
And Ian is in the interesting position of having his football club, Newcastle, doing a lot better, but maybe at the expense of the club in the place he lives, which is Leeds. More to the point, as Ian comes to visit us, he brings with him a database of hundreds of thousands of patients in Leeds who've been receiving liver blood tests for years and experience as a practicing physician. Louise, I realize I talked about you and never said hi. How are you doing today?
I'm very well, thank you very much. Again, like Jörn and everybody else, just amazed at the dynamic that's changed since the last time we recorded last week in the world. It
is true. You roll along and then bang, and things change in an unspeakably large way. Fourth, our rookie guest, Chris Estes. Chris is not a rookie in any sense of the word except on this podcast. Chris has been discussed indirectly on the podcast when Stephen Harrison has come on and talked about Arun Sanyal, a paper that he credits to Arun Sanyal, who was the last author, modeling disease in the U.S. from 2015 to 2030 and how dead-on accurate it's been on the growth rate of cirrhosis. Chris is the lead modeler at the organization that produced that paper, an author on the paper, and the lead modeler on the paper. Chris, thanks for joining us today.
Oh, thank you, Roger. I'm really happy to be here. And as with everyone else, my thoughts are with Ukraine today. Really happy to be here today to discuss the liver disease modeling.
Thank you. So, Chris, because you've not been with us before, do us a favor. Take a couple of minutes and tell our audience a little bit about yourself, what you do, how you got to the point where you're doing what you do. Then, when you're done, one fact that we wouldn't know about you if you didn't tell us. Now, you've got some tough competition. We've had professional athletes. Last week, we had a patio furniture maker and two people who both emigrated from Ethiopia at the age of 14, although they were not 14 at the same time.
Oh, wow.
So you've got some tough competition on this one. But floor is yours, my friend. Go ahead.
I've been working in the liver disease field for about 10 years. At our organization, Center for Disease Analysis Foundation, we're a nonprofit, and we really use epidemiology research and mathematical modeling to help decision makers understand poorly understood of diseases. So we've published multiple papers on the global burden of HCV and HBV, and we have models for almost every country in the world for those diseases. Now we've expanded into NAFLD, and we have mathematical models for about 16 countries. And really these have been used to understand what the future disease burden will be and to help decision makers see how this is going to impact them in the future in terms of both disease burden and economic cost. Before I was in the liver disease field, I also worked at CDC previously on occupational health, looking at injuries and fatalities among workers, especially injuries among younger workers. A fact some people may not know about me is before I got into epidemiology, I used to work in a clinical lab. So I have hands-on experience with doing some of the actual testing, biomarker testing, genotyping, and things like that, actually doing the procedures in the lab.
That's great, Chris, and thanks for that. Something that Chris didn't even know about Chris before we spoke is that he and I have had two rather interesting geographic misses in our lives. A little bit like Zaki and Yanni both having left Ethiopia at age 14, but years apart. These are years apart. But Chris, his undergrad is from a small college in eastern Pennsylvania called Albright College. I've had three great romances in my life. I married my first. That turns out to have been a mistake. I am married to my second. My third, that turns out not to be a mistake. But the one in the middle was a woman who went to Albright College, who I dated for 3.5 years and was briefly engaged to. So it's a small college. Not a lot of people know about it. I think Chris was surprised that I knew as much about it as I did, but I wound up going to Albright dorm reunions every year for a couple of years. So that's number one. Number two is, many of you may know, before I started this podcast, I ran a marketing research firm for 30 years. And that research firm was started about 2 blocks from the Drexel University campus in Philadelphia, which is where Chris did his master's. Again, as I say, many, many years apart, but 2 points of geographic juncture. And I think you're the first person we've ever had on the podcast that I've had that kind of thing with, and we've had 60-something people on by now, so I guess it had to happen eventually. So here we are. With that, let's go to Groundbreaker. Okay, really? Oh, actually, let me mention first, Stephen isn't with us today. He isn't with us because he was supposed to be flying to Singapore to spend a week with HistoIndex and record Wednesday's episode with us. He did not go to Singapore, word to people who want to travel to Singapore, because he needed a QR code authorization from CDC to prove his vaccination status. Wasn't aware of that, never got it, so he couldn't get on the plane. However, he couldn't make it today anyway and expresses his regrets because I think he'd be one more fantastic contributor to this episode, as he is to everything. With all that out of the way, let's just go to Groundbreaker. It's been a tough week in the world, but let's see if we can find one good thing, however small, personal or professional, that happened in each of our lives in the past week. Brave one, go first.
Let me start out, Roger. Of course, my personal highlight is coming from the week of vacation that we just returned from, the Austrian Alps, going skiing, and again had my 6-year-old on skis for the first time. She did pretty well on the third day, which I think sometimes it's amazing how fast kids can adopt to certain things. And they had a little contest there. I'm very proud to make it to the finish. So I think that's a clear highlight. On the other side, professionally, I'm very excited to be here with you, Ian, and of course, meet Chris Estes face-to-face for the first time. He's first author on a paper that actually belongs to one of my more cited co-authorships. So I'm very pleased to actually meet him and happy to discuss further.
I'll jump in next. Whilst I've got a lot on professionally, I can't talk about the moment, which is always exciting. But personally, I was at Wembley yesterday for the first time Liverpool have raised a trophy with a crowd in the stadium. Because we couldn't celebrate winning the Premiership since the pandemic started, so it was a great atmosphere. It was also great at the beginning. We all clapped for Ukraine, and we sang for Ukraine, You'll Never Walk Alone, because they're certainly not walking alone. Maybe difficult, but it's an appropriate anthem for Ukraine at the moment, I think. But yeah, we won on penalties, 11-10. So I'm happy.
Arguably the craziest football match I've ever seen in my life. It could have been 5-5 as easily as 0-0 if the keepers weren't so good.
It was the most entertaining 0-0 draw that you will see for a while.
Yeah, and then no one misses a penalty until the second keeper. Yeah, okay, Chris, Ian, go ahead.
I'll jump in next time. It was terrific yesterday. I think it's the best 0-0 I've ever seen. My eldest son is a Liverpool supporter for reasons that I can't explain, but he was very excited, extremely excited. My personal highlight actually relates to our middle child, who at the beginning of the year we each set ourselves goals. I'm not going to share what mine is before anybody asks, but his was to learn to ride a bike. He'd been quite reluctant before, but by the end of yesterday he was cycling around, and having previously not really seen the benefit of it, he felt that freedom and off he went. So that was a heartwarming moment in difficult times.
I have to apologize. Being American, I'm not up to date on all the latest football happenings. Yeah, I guess my excitement from the past week is I live in Colorado. We've had a lot of snow recently in the mountains. So I went snowshoeing with a couple of my friends, but we got a little bit lost and it started to get dark out. So that was pretty exciting. We did eventually find the path back, and we got back passed the car before it got dark. It could have been pretty bad. We got actually been truly lost.
I don't even know what to say to that. I can go anywhere from, boy, I'm glad you made it to the podcast. It's just you probably learned a couple things about what not to do next time. But
definitely.
So my personal is really simple, which is that my kids had a wedding they had to go to this weekend, to which their 4-year-old daughter was not invited. So my wife and I spent 2.5 days with our granddaughter, who is of an age where she has decided that G, which is my grandfatherly name, is the best man in the whole world. So all she's wanted to do for the last month and a half is go out on a date with me. And I'd say, so where are we going? She says, for chicken fingers and fries and chips. And should we bring Nana? No, G, this is a date. So we went out on our date on Friday, and it so happens that one of her favorite people in town is a waiter who was serving lunch on Friday at a place with the best chicken fingers in town. You never know what experience gets burned into your kids' brains, your grandkids' brains. And Ian, the reason your son is rooting for Liverpool is because you're not, right? That's how it works. Either he becomes a complete devotee of what you're doing or the opposite thereof. And since you don't live in Newcastle anymore, I could see why that you're not is a high probability. The biggest Yankee baseball fan I know lives in Washington, D.C., where his son is rooting for the Washington Nationals, the local team, and he is beside himself. But at any rate, I don't know if that day will be burnt in her brain forever, but it will be burnt in mine. And it was the 90 minutes of the day that I did not look once at the news on a tough day. With that, why don't we dive into today's topic? I think I've already explained what we're going to be talking about. We will post the nice statement on the website with all of the episode briefings so that you can get after it if you want to. But I think right now we should just kind of dive in. So I'd like to ask each of you folks, having looked at the statement, to take a couple minutes, 2 or 3 literally, as much as 5 if you need them, and tell us what you see in that statement when you read it from your unique perspective. Brave one, go first.
So I'll jump in, Roger, because I think there is a bit of context for the listeners about what the role of NICE is in the UK. So NICE is there to provide cost-effectiveness analyses for the whole of UK healthcare to allow rational, in inverted commas, decisions to be made about healthcare spend, both mostly from a cost-effectiveness and clinical effectiveness perspective. The analysis that they were asked to do, or had commissioned, was around looking at the use of transient elastography or FibroScan in primary care or community settings as opposed to its delivery in secondary care. And that's a very tight question. It sort of suffers a bit from a lack of data about both how well the test works in primary care, but also some known data gaps. And those particularly cover what happens when a patient's had a scan result and whether that alters the trajectory of their disease. That is and remains a really important data gap from a trial perspective, but also from a sort of real-world data perspective too. So that the outcome of the decision-making from NICE is a function of the question that they're asked and the data that they're able to see and the relative costs. It's an understandable decision, but it may not be one that benefits the wider patient pool in the best way.
So do me a favor, elaborate on that a bit as somebody, remembering that they have comment period, as somebody who has bunches of data on things that are at least related to this issue. What do you think is the data they would benefit most from? What are you aware of that's available right now that might be brought to their attention that might help them view it differently? Or is anything complete enough yet to do that?
I'm not aware of any data that comes directly from primary care about the use of elastography where it's not being guided through a care pathway and a secondary care service. So in Leeds, we set up a community hepatology pathway, which involved one of my colleagues going out into primary care and delivering FibroScans there. And that was very well received by patients. They liked the convenience. They liked not having to travel to the hospital. They liked getting the results there and then from the clinician who was doing the scan. But that was secondary care service delivered in a primary care location. There are clear benefits from a patient perspective to delivering care in that way, but from a NICE perspective, there's no exclusively primary care delivered service with which to compare. So we don't know how well the tests are done, what information is given thereafter, and whether that changes the patient's trajectory. And that, I guess, is the big issue, is that how would FibroScan testing in primary care be regulated is the wrong word, but controlled so that it was being done within a defined clinical pathway so that the right patients were either referred for further evaluation or referred to community weight loss services or alcohol cessation services or whatever, so that their patients were getting the right information to help them to improve their health.
Okay. Ian, that was a really helpful statement and a great start. Anybody who wants to dive in next?
I'm going to dive in next. Ian's absolutely correct in everything that he says about NICE. I think NICE is a completely valued body, having sat for the RCN, gone through hepatitis C, and I think it can make some great judgments. This is through a diagnostic part pathway. It is not being considered realistically within liver disease as a whole. It's purely about the diagnostic test. What I didn't hear at the meeting was that there were anywhere else considered where this test could be done. It seemed to be that it was discussed in the premise that, like a radiology department, and it was two radiologists, if I remember correctly, that did the presentation. So they weren't from a hepatology background, they were from a diagnostics background where you deliver diagnostics tests. So my take home from the way it was being viewed was the same way that people misconstrued it, is that because it says scan, that it's done in a diagnostic scanning department in radiology. 100 patients will come through the door, have their test, and 100 patients will go out of the door. So it has no direct impact on the population within the department. Ian's quite right. This is not how FibroScan is delivered in the UK, and I'm not too sure about elsewhere. This is all specialist delivered. 2018, I think there were 375 FibroScans in the UK, 55 of which sat in London, all in specialist departments. 70% of all of those devices did not have CAP capability. So we are talking about very, very small cohort. But for every 100 patients that comes through a department, say my big department in a central London hospital where I worked and built a FibroScan service, we would take 30 of those patients and add them to our lists, which therefore maxes out the capacity as you go down. Every time you do a list, you take people off it and send people back to the community. These nurses are now reutilised in looking after sick patients, using specialist nursing teams to deliver either in-reach to secondary care or outreach. As Ian's quite right, there is not a primary care direct referral service that is not delivered through a secondary care specialist centre. So there is no access to the normal population to FibroScan. I found it very interesting at the beginning when I say that they're into diversity and equity. The British Liver Trust published a great paper last year that said 75% of our country do not have access to FibroScan. This doesn't change that standing. It also continues to remove all access from low socioeconomic, diverse communities who do not interact with secondary care, people who inject drugs, sex workers. We keep this diagnostic in a very select community of people who access secondary care. So it doesn't tick any of those boxes for me. The other thing that was very, very prominent, there was not one discussion on how COVID has affected the diagnostic pathways for liver disease or the need for diagnostic pathways for liver disease as relation to the pandemic. And I don't think there can be one discussion that NICE now has that does not consider the effect of the 2-year backlog in waiting lists that we've got and how we're going to build back better if we do not utilise diagnostics. And the third thing that really stuck out to me was there was an assumption that every single inpatient area in secondary care costed FibroScan the same way, so that the costs were equative on their cost modelling throughout the country. I know no two units that cost FibroScan the same. I know one hospital that costs it at £450 a scan. I know an inner London hospital that puts a nurse tariff, a FibroScan tariff and an ultrasound tariff for the same appointment. So, and this is mainly because FibroScan, when it first came out, was too new a device and it was never costed through HRG4. There was never a pathway developed for it. So every single hospital had to develop their own way to get money in on it. Their cost modelling never considered the fact that nobody costs it the same. So therefore you cannot do a cost model if that's the case. If you are a secondary care department, and we did outreach into drug and alcohol services, but if I have one nurse sitting there all day who does 2 scans, that makes that scan way more expensive than doing it in a secondary care location. That's just basic economics. So to say that it was more expensive in the community than it was in the secondary care, it's the same units providing it. But the one thing we remove when we do access in primary care is remove the £209 tariff that every single patient in my hospital had to pay, or CCGs had to pay, to even get the request for a FibroScan, which is where bringing it into the community removes that tariff, and it's only applied then to the people who really need it. That wasn't discussed. Neither was the discussion of different pathways. You go to dermatology and then you need a FibroScan for methotrexate use. You need to go back to your GP. You need to go back into... There were lots of things that I thought were missed on just the basics, and that doesn't touch on patient care.
So let's step it back for a bit, okay? Because for the portion of our audience that lives in the UK, all that makes a lot of sense. There is a broader question at hand here. Ian says, even within that narrow window, there are a lot of things they didn't see. So not only a narrow window, but a dirty narrow window or a narrow window without really good glass. I'd like to broaden out the frame a little bit. So Ian goes back to, what do we think the rational economics would likely be if we knew how to evaluate, or if NICE were able to evaluate this through the context of its impact on care, rather than simply at the very kind of micro, single event, funky economic level that you just described. And to that, I'm going to ask Jörn and Chris what they think, if either one wants to start there. Okay, Chris, go ahead.
Yeah, so when we looked at this, from an economic modeling standpoint, when you have, a screening program like FibroScan, and, just the background of FibroScan, we know from the Barcelona, Rotterdam, Hong Kong cohorts that there's 5 to 10% of the general population with elevated liver stiffness, and they're asymptomatic. So the FibroScan does have this potential to identify these people. But you have to reconsider the cost of the technology, the FibroScan itself, the cost of the intervention, whether that's weight loss or some potential therapeutic. But then when we look at what costs we get back, we look at that in terms of how many cases of liver cancer would we prevent, how many liver transplants are prevented, how many fewer decompensated cirrhosis cases are there, because these are the costly end stages of disease. But another important component of that is to look at disability-adjusted life years or quality-adjusted life years, and these are the indirect costs. How much lost economic output, how much lost work productivity. And when we think about therapeutics or interventions, it's not just liver disease. If we're addressing NASH, we're also going to reduce costs associated with other facets of metabolic syndrome. So we're going to have reduced costs potentially for hypertension, reduced costs of managing dyslipidemia and diabetes. So it's kind of a multifaceted approach. You have to look at what the intervention and the screening will cost, and then what the outcome will be. And not just over the next few years, but over the coming decades. For example, if you can prevent someone from becoming obese, from ever developing NAFLD, that's actually the most cost-effective way of addressing disease. So it's kind of looking at inputs and outputs as well.
Chris, I think that's really well put, and it highlights that missing piece of data. So as part of the submission to NICE, EchoSense, the manufacturer, they provide the economic model, and then it's scrutinized and further developed. And the major criticism of their model is that it's at a 1-year horizon. So really, it's unable, because we don't know what the impact downstream of the test is, to provide any of that information that would be so valuable in terms of determining lifetime cost effectiveness. And it remains a gap in our communal knowledge about the impact of test and treat strategies for liver disease in general, not just for NAFLD.
Ian, would you bring in the data, therefore, that we've had a success from treatment of hepatitis C? Because, of course, we use FibroScan to assess, to get patients to treatment for hepatitis C. We then, most units then monitored them out, and we've seen a huge regression in fibrosis stages in the ones that we've cured. Is that the sort of data we can use to model? Because we've got a lot of data from the UK on that.
Probably not in this context, because the FibroScan wasn't the indexed diagnostic modality. That was the hepatitis C PCR, and the FibroScan was simply there for staging. And because of the way the reimbursement was developed at the time that the DAAs were licensed, the FibroScan had a more prominent role because we set a low threshold to diagnose cirrhosis to maximise treatment. It's a useful exemplar for how a service might work, but it requires an entry test, and we might come on to talk about what that entry test might be. And I know that Jörn's been itching to come in.
Thanks for that pitch, Ian, and again, very interesting discussion, and also for putting it into perspective. Having to look at this, being a non-UK practitioner, I think in my system it'd be the same, where it would be crucial that reimbursement codes are available for practitioners to be able to use this type of test. And the currently available reimbursement codes, which would reimburse for ultrasound, are not the ones that a practitioner would require for implementing such a device in his primary care setting. Having said that, I think the total healthcare setup is a little different with a less structured referral pathway. You can't compare it head to head. From my perspective, looking at it as a hepatologist perspective, I think it's also very different from the Hep C field, Louise, because as Ian mentioned, the entry criteria, identifying a disease that's then treatable with a success rate of 95% will give you you very different outcomes. So from my perspective, it's very interesting. This discussion is brought forward because it addresses fibrosing liver disease. And we know that the fibrosis degree is detrimental and has a prognostic value. Now we're trying to implement a diagnostic test, and there's good evidence, or there's good rationale to support that if you inform a patient that manifests in primary care, you identify a patient in primary care with advanced disease stages, you have more opportunity to prevent, potentially treat in the future. So from that perspective, I strongly support this type of testing to be implemented early and be able to provide some preventive measures. Now, there's at least one research consortium funded by the European Union, the LiverScreen Consortium, and Chris mentioned some of the earlier data that is actually trying to provide or generate some of that data, looking at general populations and referring patients for subsequent testing at a liver scan result of 8 kPa. Moving forward, we'll see more data emerge from Europe, and I think that's required for it to be adapted. On the other hand, I do see the problem that you have a new test. It'll be very difficult to talk about 10-year outcome data, and the question is, how can we use that to the benefit of our patients today? So I guess that's my lines of thinking here, and happy to discuss further.
So, Jörn, I want to chase your question a little bit further, right? Which is there a way to think about this a little more expansively where more is known, or where we can do a better job of pinpointing what needs to be known in a way that it can be known quickly? Last week, we talked about NAIL and IT 2 weeks ago. And one of the things that Stephen and Mazen were talking about, in fact, they're talking about your retrospective analysis being able to produce some results within a year. Idea being that we probably know more than because how the liver functions and the time continue on these diseases. If we have to set out prospectively to prove things, that takes a long time, even if you're really careful about how you do it. But if you can make better use of data, now I'm not sure NICE operates this way, but are there data that we can make better use of, Jörn, Chris, Ian, Louise, whomever, that would start to provide faster answers or a better understanding or even a better pathway for how to study this issue further?
I'm just going to jump in. We need to consider the whole. Where this sits at the moment is very singular and siloed. They did make comment in relation to where NICE have also advocated for FibroScan and non-invasive diagnostics, and that was in hepatitis B, hepatitis C, NAFLD, alcohol and cirrhosis pathways. Now, they are very niche pathways, and the irony is that in the last 12 months, APASL, EASL and the AGA have approved pathways to get earlier non-invasive diagnostics in a stratified way with FIB4 followed by ELF or another diagnostic or FibroScan, which the NAFLD guidelines here were written in 2015, which is, given the speed of technology, things have altered rapidly, but if we were to go with what we've got now, we cannot rewrite those guidelines in a way that the AGA, PASL and EASL have done, because we just would not have access to enough equipment throughout, and that was one of the reasons it wasn't put in originally. So I do think there has to be less of a silo consultation on the only non-invasive diagnostic that's a point-of-care diagnostic for liver disease. So I think it is unique in that sort of setting for that. The other parts of the data they used to work out some of the costs when they did their review were key articles like Shrivastava et al., where primary care, he used his primary care, incurable cancer rates decreased. So although they used it to work out costs like £35 or £40, and all of these articles guessed, not one of the articles claimed to know the correct price of FibroScans. We didn't work on great data. One of the other articles they used was the Chanajewski et al., which showed that you get a QALY of 2,138 for patients with NAFLD, but 6,537, so taking up on Chris's points, for alcohol. So we have data. They use those same articles to come up with cost. So therefore we need to be able to use the information that, for me, that was gained in those articles for the cost saving and the qualities that this brings back, because it is data. So if it's acceptable for one side, it has to be acceptable for the other, because I think we also have to reflect that the default position, if you do not have FibroScan, is a liver biopsy. And if that cost, therefore, should be worked into the pathway, that if you have no other option and liver biopsy is your fallback, then surely that, for me, would need to be in the costing scenario, because that is the only other option for these patients.
So I think there's a couple of questions from the sort of NICE perspective that we should ask ourselves. First is, do we think it's desirable that elastography or FibroScan is delivered in the primary care setting? And I think the answer to that's yes. The second question is, how do we get there? And I think NICE have told us for the UK what we need to do, and that is a comparative, or essentially a test-retest study where a patient comes to primary care and comes to a hospital setting. Now, it may be, depending on Ecosen's appetite, that they would be willing to set up a study like that in the UK. I think it'd be relatively straightforward to do, and I think that people would want to do it. The question would be whether you would need a gold standard assessment of fibrosis as part of that. So liver biopsy, one would hope not nowadays. And I think that that's really all NICE are asking for, to show that performance is the same and that there's some assurance that a referral pathway or pathway of care is being followed for patients. Now, in Leeds, we're almost there really, because our risk stratification for patients with an elevated ALT coming to our clinics now includes a FibroScan that's requested from primary care. Now, it's delivered by a secondary care clinician, but it's essentially a primary care only pathway. The issue is, as Louise will well know, that as soon as we opened the pathway, the floodgate opened and our waiting times have extended really very quickly for FibroScan, and we're working to bring those back down again. And some of that is increase in testing after COVID. Some of it is really recognition that our pathway now works very well and that primary care have engaged with it. But with it being new, what we've seen is the letters from the primary care clinicians who've got a result that says median liver stiffness is 7.2 kilopascals. I can't interpret this. I don't know what to do. Tell me. So the how is very straightforward in terms of what we need to do, but what happens downstream in terms of coordinating pathways that are delivered exclusively in primary care without the involvement of secondary care will need some more work as time goes on.
I think you're right there, but the premise for NICE was that, and in the document it states that they were concerned that basically Ecosense weren't providing an ongoing supervision and the quality in the scan, although they accept that all of the experts, and I was one of those experts consulted, said that if you've got well-trained staff doing FibroScan, it doesn't matter whether it's done in the community or the secondary care, it's about the quality of the scanner. What they seem to be suggesting, which I don't think is equitable throughout diagnostics, is that is provided by the company who sell the machine. I don't think that Philip and General Electric provide the same, or are asked to provide the same for ultrasound provided by GPs in the community or community nurses, and to provide that ongoing supervision. That surely is down to the governance of the purchaser to write the policies, the procedures, and to ensure that my staff or those staff are highly trained, qualified, and get assessed. So we provide, for example, bringing Towers and Health into this now, we provide everything NICE has asked for. Highly skilled, highly qualified users where the quality of the test is the same in community or secondary care, wherever we provide it. We weren't asked to give a costing, and I don't think any other private provider has been. So it's purely considered in the case of how would a secondary care service provide this. It doesn't take into account the breadth of knowledge that is needed or how to apply it. Yes, they're right in some extent, and I'm all for the quality. That's why we're CQC regulated. You cannot remove that quality, because if you just let it out there, I know a lot of people see one, do one, show one. And you cannot do that. So I totally agree with NICE in some respects, but I don't think that is the accountability of a company to provide that ongoing, where it's not asked for another diagnostic equivalent.
To extend this discussion a little bit, and I think Ian mentioned this briefly, is really, do we require, or do we think an entry test would be the way to go? There's German guideline for NAFLD coming out that will, like many guidelines are discussing now, will probably require metabolic risk factors, fatty liver on ultrasound, or lab abnormalities as an entry criteria for then use transit elastography. And the thought behind this obviously is to enrich the at-risk population and have a total different population. Whenever you're asking for data, it's very critical to actually look at the population that's enrolled, because pre-test probability will affect all these numbers that Chris then uses to calculate the models are so crucial. And I don't think we have a uniform study or a patient population that's been selected like that we can use to actually come to a concluding answer. There's a lot of studies that do look at the diagnostic modality in terms of accuracy, but again, the entry criteria, which patients are studied, are critical. And maybe this is something that Chris might discuss further or comment on. Depending on what population goes into your model, the outcome will be very different. Or even as Ian has experience with this, I think this needs a lot of thinking.
Yeah, when we look look at costs, we look at a cascade of care. So you would be screening a general or an at-risk population. And then of those that are positive, then those people are going to incur further diagnostic costs as you try to do further testing. And then you have the cost of these people have to be under care. And then they also have to, if there's an intervention, those people have to be enrolled in the intervention. And at every step of the way, you're going to lose patients. So one example from the US is that when people used to donate blood, and they tested positive for hepatitis C, they would get a letter in the mail saying, you donated blood and you were positive for hepatitis C. And if you follow back with these people a year later, a lot of them weren't even aware that they were positive. Because they received the letter and there was no further action, no one linked them to care and there was no intervention. So when we look at the FibroScan, we have to think about what are the downstream costs and what will be the future costs of the intervention. So, one way you could look at it is people with elevated liver stiffness. If those people were then enrolled, say, in surveillance for HCC, liver cancer, because we know that people don't have to have cirrhosis to develop HCC. They could have asymptomatic NAFLD, NASH, and then develop HCC from there. So if they have elevated liver stiffness and they're actually enrolled in enhanced surveillance of liver cancer, how many early cases of liver cancer could be caught early? And, would be the disease and economic burden averted as a result. So it's kind of looking at this cascade and, the different levels of actually getting patients screened, further diagnostic testing, enrolled in care, and then the intervention itself.
Chris, you ask a great question. Is there anywhere that you're familiar with in any of the countries that you're looking at that has any data that looks like it might be an answer, not necessarily to NICE in the UK, but just in general? Can you presuppose some of that based on data that you've seen or modeling even done?
The FibroScan studies are still fairly early, so there hasn't, they've gone into general population, and these are kind of done at tertiary care centers. They're not done in a large scale in the population. So I'd say, like right now, they're more investigatory. One thing that would be also helpful with looking at FibroScan data is to have more longitudinal data. So right now, a lot of the published studies are cross-sectional where they look at a single group of people at a single point in time. And what we need actually is follow-up, how their FibroScan measures are changing over time. Because this has always been the challenge with modeling NAFLD and NASH is the huge uncertainty around progression rates. And a lot of the progression rates are based on liver biopsy studies. But we know there's a huge variation in liver biopsy just depending on where the liver is sampled. So this is kind of what we don't know is if someone is F1, what is their likelihood of progressing to F2 in a given year, given a set of risk factors, or what even is the risk of regressing back to F0 given a certain set of factors. So it's kind of getting this longitudinal data with FibroScan, combined with FibroScan would be really helpful for modeling and understanding the future disease burden.
Can I ask you, Chris, have you done any of the modeling with the scenario of the post-COVID pandemic delaying diagnosis in most of these diseases and conditions? We're talking about 2-year backlogs. I certainly know some units that have longer than that. We're doing a project at the moment with somebody to try and clear their list in 6 days. So with the increase in alcohol consumption and the increase in BMI, if you were to model that on what you had previous to the pandemic, what numbers are we talking about increase that we've missed? I know that the Lancet Commission said we may miss 46,000 cancer patients a year for liver cancer in Europe. So do you have any modelling figures on non-diagnostic effect?
We haven't looked at that specifically for NAFLD. We have done a modelling exercise for viral hepatitis where we've looked at what's happened now that we're, the treatment with the new therapies coming out for HCV, what's been the impact of this we call it a 2-year delay. And it turns out that the impact is going to be greater than just would appear apparent from the 2-year delay. You're going to have more liver cancer cases, more cirrhosis cases potentially for years and years to come, just from these people not being screened and diagnosed. So it's a long-term impact. It's not just going to last 1 or 2 years.
That's my concern. This document is being proposed now with no discussion of how COVID could affect the diagnostics for liver, and it won't be reviewed for 3 years. So therefore, we would be without FibroScan in the UK and in a lot of other countries that look at NICE when they deliver a suggestion or a guidance for over 3 years while we're actually building back from a pandemic. What I would ideally like to see is I agree with a lot of what's in the document for good reasons, but I would like to see this now being done in conjunction with a pandemic and given draft approval for figures to look and collect all of this data that they want and ask, but also to help fight back better. If you look at Harman's studies, you increase the diagnosis of cirrhosis by 140% if you use FibroScan in a community setting. These are the ones we're most greatly going to miss. Rather than stop these documents coming through from any speciality through NICE, we need to put them into a pandemic discussion and have that at the table. So even a pre-approval to get the data, because this is a device that helps us get ahead of the curve to some extent. We all use it in secondary care, and we can develop those pathways as we build back. So I think that might be something that I would like to see considered, rather than just carte blanche, let's not use it at all for 3 years.
I guess the challenge in this is, Louise, that the situation is so dynamic. It's probably difficult for a model to capture this, and we're talking about confounders here. Of course, this is a pretty big and long-term confounder, but I do see that as a challenge. And the problem with these consultation guidelines, also as I experience these from other countries, is that they're not as dynamic, or can't be as dynamic, because you need to generate the data and the outcomes. So that's the downside. On the other hand, again, it's very encouraging that these type of discussions are ongoing. And as Ian said, I think there are some target conditions being defined and some knowledge gaps being raised. And that's really one pathway that you can move forward on to then define the benefit in these effective modeling in the end. And I think this is a first important step to then implement this type of care. And again, the big difference for me is that we're talking about fibrosing liver disease. This moves beyond the presence of NAFLD, what we discuss a lot. It's about identifying relevant liver disease, as you said, identifying compensated cirrhosis, where probably the biggest benefit can be made in the short term. So my take home is that we're setting up this study. We should take populations that are severely liver diseased and follow them up for a short period and show a benefit, and that will then allow us to make recommendations and come up with data in a shorter time frame.
In some ways, these decisions that, although it's not finalised, sometimes feel as if they're going against us, help us in the longer term. And I think a lot of the data that you've referred to, Louise, from, whether it's from Camden and Islington or from the Nottingham Scarred Liver Project, that's still, it's primary care testing, but with secondary care guidance. And we probably shouldn't forget that NICE already support direct to FibroScan testing for patients who've got hazardous alcohol consumption. In many ways, we're quite far advanced in identifying those patients, as Jörn said, who've got fibrotic liver diseases. The bigger question is whether a FibroScan done in primary care setting or delivered by a secondary care person in primary care, really, whether that really matters, and what the best pathway to get there is, whether we can afford to, whether it would be right to FibroScan everybody who's got a metabolic risk factor, or whether we need to make the pathway slightly longer so we don't lose patients, as Chris says, with repeated testing and failures in linkage to care, so that we're rational, efficient, and patients get to a diagnosis quickly still. That's a remaining open question about how we best manage those patients at risk.
Oh no, and absolutely agree with that. There are additional pathways that have been suggested. There's a sequin here for everybody who's been admitted for 24 hours to an emergency hospital, whether in mental health or in acute setting, is offered a FibroScan. Now that cannot happen because nobody has access to it. The National Health Service health check for everybody over the age of 40. If you have an audit score for alcohol of 16 and greater, you should be offered a FibroScan. Your GP does not have access to deliver or comply with these tests. So none of these two areas weren't discussed in this document or put forward. So the NHS is approving pathways where FibroScan is advocated for with no access to it. So it allows non-compliance. Nobody can comply with the Sequin 2021, which was rolled over, because nobody has access. Nobody can comply. And that's one side not speaking to the other side. But from a patient perspective, I don't necessarily want to have a biopsy. I don't necessarily want to travel to be told that actually I'm the 9 out of 10 people who didn't need to come here because I've got a soft fatty liver. This is what not giving a diagnostic test does potentially raise from my perspective. But we exclude the most vulnerable people with usually the highest rate and risk of liver disease because they don't want to access secondary care. And this isn't going to currently, in its format, assist that. And I don't see how we target the highest risk populations without access to a way to solve it, I suppose, that allows us to do it in a timely manner, given the increase in disease we're going to see.
So mostly I've listened. I have a couple of rather specific questions based on kind of everything I've heard. First one, this is to Chris. It's a word that Louise just used that I think I know how to answer this in the U.S. I assume it's going to be the same in the U.K., but I want to make sure I'm right in the U.S. first. Louise talked about lower income people not wanting to go to secondary settings. I think part of the problem that you see is that, because it's the same thing with COVID-19 vaccines, right? You had people who wanted the vaccine but either didn't have transit to get there or couldn't afford to take time away from work and childcare childcare and had no backup provision to do so. A, is that what you would expect to see if you looked at it? Have you looked at it in the States or in the UK? Is that what you would expect to see if you did? And then I'll turn to Louise and say, when you say want to, is that really what you're talking about? And I have a couple more questions after that, but let's do that one first.
I mean, in the U.S., the populations that we think of as being, very high risk of NASH and NAFLD are especially underserved. In rural areas, there's very little access to specialist care. People under 65 without good health insurance, this is a very U.S.-specific problem, but if you're under 65 without good health insurance, the cost for specialist care can be prohibitive. Found, general population interventions really need to involve primary care, and this is just due to capacity. Even countries with a large number of specialists can't enact large screening or intervention programs just using specialists alone. The primary care is really essential. And if you think about underserved communities in the U.S., that's all they have access to is really primary care. Traveling a long distance and incurring high costs is just not an option, especially for those most at risk of NASH and NAFLD.
I guess my point is that that's not an issue of want. That's just an issue of socioeconomics and the structure of life and need and demand on time and all that stuff.
In the U.S. and in other countries, we know that obesity and metabolic syndrome can be correlated with socioeconomic status. So people that are lower socioeconomic status have less access to health care and pay a greater proportion of their income already for health care. And they're not in a position to actually, especially in rural areas, to travel or incur extra costs for care. And we know with COVID, the latest data are showing the opioid epidemic has increased substantially. And Louise mentioned the increase in drinking and obesity. So it's a perfect storm now where you have people without insurance, worsening health indicators. So it's kind of a perfect storm of risk factors here.
So that was number one. And number two, and this is to the group, I'm saying if I understand this right, some of this conversation is directly relevant and some of it kind of talks past each other, by which I mean, I hear the argument that goes on the one hand, we probably don't have enough data to make a complete case. Louise just suggested that in some situations, if this ruling were to go into effect, it would mean that other things that NICE was advocating couldn't be executed because you couldn't get the machines to the site where the people have to be cared for. Do I understand that correctly? That those are really two different issues?
Kind of, Roger. I think some of this is around the way that healthcare is organised and reimbursed in the UK. So the NHS has a responsibility to adhere to NICE commissioning statements. So if NICE says drug X is cost effective, then the NHS has to provide it. But at the same time, the NHS can work outside NICE because NICE cannot provide guidance for all circumstances. The sequin that Louise referred to about alcohol testing is a sort of illustration of that, where the clinical reference groups have identified an area of need and have suggested an intervention, in this case liver testing for patients who are alcohol dependent or consuming alcohol hazardously, but without a NICE recommendation in the background. It's a tension in the way that the system's organised, not necessarily a real issue.
Okay, until the last sentence, I was right with you. How does something's attention in the way the system is organised become a real issue or not become a real issue?
So commissioning will sometimes recommend services that are not NICE recommended. The DAA situation was probably the best example of that. We were receiving recommendations about which DAA to choose based on commercial agreements and data that was early before NICE could give an opinion. That wasn't necessarily... There's a tension then between the NHS and between NICE, but actually we were practicing with contemporary data with the best drugs to use at the time. In this setting, it's a bit different. The sort of diagnostic need is not the same, I don't think, for those patients who really needed hepatitis C treatment. It's quite different.
The crucial difference here is, of course, that with a pharmacological agent being approved and being prescribed, you're going to make different revenues than with the diagnostic tests. So there's a different willingness of a company to invest upfront to get a drug approved versus a diagnostic test approved. And I think this is one of the big differences here. It's a burden to diagnostic tests because if you need the same study setup show outcome improvements for a diagnostic test versus a treatment, that's of course a hurdle for diagnostic tests. Where I think the differences in reimbursement are not as big as in pharmacological arena. Another important aspect that we haven't addressed is how can we promote health instead of identifying disease. This is where these type of diagnostic tests come in, but this is also where the healthcare system struggles because many times we only pay for things in a diseased state where you have the HCV RNA positive. But if we have the option to intervene and provide prevention because somebody is identified through a diagnostic test as being at risk and we prevent something down the line. I think we've discussed this. It takes a long time to improve and then address this, but I think this is the true benefit. Maybe that's why the healthcare systems struggle with the assessment of the benefit in this context here.
I agree with you in the context that the narrative has to change to wellness, and NICE and everything is an illness-focused system. But I'd also like to propose a set of research that we look at how much sorafenib and end-stage HCC treatments that NICE have approved are used over the next 3 years in patients that they have had a FibroScan or earlier non-invasive diagnostics and picked up in the community wouldn't have needed to be prescribed, because sorafenib, the cost per patient of sorafenib and the other approved agents is very large for a 3 to 6 months extension of life. It was raised in a conversation a couple of weeks ago with a HCC expert, Pam O'Donoghue, and actually it pales into significance how many FibroScans that we could get done. And we've already seen data that, and FibroScan in the community, Dina Mansour's study, I think it was, also showed the great pickup of HCC or people at risk of HCC for monitoring to pick them up early so that we don't need these drugs. We are going to see, as Chris has already suggested, a big rise, the perfect storm. And if we don't pick these people up earlier, we're spending more money, very expensive costs at the end.
So we're past an hour, so I want to start to go to final question, and final question is going to be 2 questions, okay? Number one is, within the confines of how NICE operates, what would you like to see them do on this round with this issue? And then the second was, if you could wave a magic wand, what else are you confident it would be a good idea to do? Please note, I changed from what do you like to what are you confident of, because we'd all like to see everything, and having spent, pardon me, this is going to be a metaphor that might offend people, having spent the last 2 days trying to explain to my 4-year-old granddaughter the difference between what you want and what you need and what you neither want nor need but just want to stamp your feet about. On the first one, I'd like to do, consistent with their charter, what would you like to see them do? And then, regardless of charter, what are you confident would be a good idea for them to do? Brave one, go first.
Oh, I'll be brave and jump in. I would like them to get the actual costings right and go back to every unit in the country who runs FibroScan and look at exactly how it's costed so that we work out who's doing what, where and why, and what the actual costs are, because that wasn't what was described in the meeting. There was an assumption that everybody costs elastography as the same, and that's not what happens. So that's what I would like to see them take back and actually work out the genuine levels that we're charging.
Okay, and then what are you confident would be a good idea to do, even if it's not within the charter of this discussion?
I suppose what I'm confident that I would like to see is the consideration of where we are in COVID. It even entered the room and the conversation. It was not mentioned once, either in the open discussion or since then. So I think it has to be taken into consideration when you're approving anything nowadays, or not approving. You need to consider its effect for or against patients post-pandemic, particularly in liver disease, which has had such a massive impact in COVID outcome.
From my perspective, the only way forward here is a data-driven approach, and that came out of the discussion. Also, I think it's the basis of this document. So I want to see the ongoing research project. I mentioned LiverScreen as a EU-funded project that's run multi-centric across many countries in the EU to succeed as a diagnostic test, but then also to see follow-up on these patients and see what comes out of this. So I want this type of trials that actually will hand us the data that then can be used by Chris to calculate future benefits and cost savings. I think that's very important. And I can't really speak on NICE, but something that's being moved forward, that I'd like to see being moved forward, is that the context that fibrosing liver disease is a disease burden. It's a burden on quality of health. It impairs, and it incurs many costs down the road, and we need to address this. That's just something I strongly believe in, and I'm convinced that we'll see benefit by identifying patients early.
Yeah, I think the data-driven approach is important, and especially looking in long term. So a major issue with a lot of decision makers, especially government and policy, is they're only looking at next year's budget. When we think about NAFLD or NASH, if we look really long term, preventing childhood obesity, I mean, that's a fairly small cost today, but you won't see any benefits maybe till 2050. The policymakers are always just looking at what's going to happen with their budget next year. So it's really kind of long-term thinking and considering all facets of disease. It's not just the cost of cirrhosis. You have to look at lost work productivity and these other facets of metabolic syndrome and what the impact is going to be. Because as Louise said, it really is a tidal wave, and they also need to consider the impact of COVID. It set us back quite a bit in every disease area.
I didn't think Ian had commented yet.
No.
But you were being so quiet about it that I thought I might actually have missed it. Go ahead.
Now's your chance.
Well, the trouble is I don't really know what to say other than I think NICE is an extremely valuable institution to the UK, and we have to understand the impact of a cost-constrained system and making rational decisions decisions. I think it's a lot easier with drug treatments with efficacy and costs where they're measured within the trial setting, and that does make life a lot easier. And you have to remember that NICE only considers the questions that it's asked, and where they're very tight about, in this case, a single comparator, then they can only answer that, and they can only answer it with data. And I hope that we will see that data emerge, whether that's a study that's commissioned by Ecosense or whether that's a study that's done separately. That'll be an important question. The other thing that goes along with the data-driven approach is that we are currently missing a trick, and that is, we're not capturing routine data about elastography. So the document refers to a code for ultrasound-based elastography, which I think is probably ARFI delivered in radiology departments infrequently, saying that there's about 4,000 scans done a year. We're doing a couple of thousand scans in Leeds a year, so the total number of FibroScans is going to be a lot more than NICE have considered. And Ecosense have got access to that data, and I think that they're missing a trick by not looking at the individual patient data, but the accrued experience and the number of scans that are being done, because I think that would allay some concerns about the learning curve and the quality assurance issues in the primary care or community setting.
Just to elaborate on that, we perform in the UK, the last time I was aware, somewhere between 80 to 100,000 FibroScans. And as you say, I was doing 1,500 a year. And in a unit that was doing 3,500, 4,000 scans. I don't know where they got those figures from. And this is my concern about a document that's going forward not to be reviewed in 3 years, is where that information came from. It appears inaccurate at best.
Let me try to summarize. First of all, illness needs to be data-driven. The analysis of avoidance of illness or cost reduction around illness needs to be data-driven. You can't do that kind of thing on faith, but you have to do it with good data. And Louise raises the question of whether the data is good. NICE raises questions of whether they have enough of it. And Chris can work magic with what you give him. People who do what he does, but magic even only takes you so far. So that's issue number one. The other issue that hangs over all this is that wellness is a lot harder to do as a data-driven phenomenon. I mean, you could probably do it, as Chris points out, for childhood obesity, but on a lot of these other things, the data is a lot harder to produce because the cases are a lot more complicated. And in fact, a lot of this gets argued on faith, which is a tough argument to make and to win within existing systems. My first realization about health economics back a long, long time ago was a friend of mine used to say that if you could eradicate osteoarthritis in the world with a drug that you gave everybody every day between the age of 25 and 29 and never had to give it again, and it cost $2.50 a day, you couldn't find a government in the world that would support it because of when you actually experience the cost of osteoarthritis. And that is what we're talking about here, right? Not osteoarthritis, but the same basic idea, which is if you start treating fatty liver early, you're 10, 15, 20 years downstream from when you're going to get benefit. And systems aren't designed to do that or designed to calculate that. So we find ourselves in situations where we are data-driven. We have to be smarter about the data we get and get it better and analyze it better. And then somewhere to the side of all that needs to be a whole bunch of advocacy, which is what Donna does and what Louise does a lot of, and what we try to do some of on this podcast. Keeping the two in their tracks, I think, is a helpful thing, because if they cross the tracks, then you wind up making arguments you can't support, or you wind up missing opportunities you need to take. That's just a discipline. Any other closing thoughts for anybody on this?
I'm going to have one closing thought, that if there is anybody, patient, charity, or on the medical or nursing side, this document is open for comments. Please read it if you are in the UK. Please comment on it and put it back, because they will take your comments, and I'm sure the British Liver Trust will have a number of comments, and Liver for Life and PBC Foundation and Children's Liver. Everybody needs to be aware they have the opportunity to read and comment by the 9th of March, and that's all we're asking for, is as many comments as to how this affects you or doesn't affect you. So let's have them, because that's how we can have that dialogue. That's how we can bring forward how people feel about having or not having access to a diagnostic.
Okay, let me do this. Let me, first of all, thank everybody for joining today. Chris, thank you, and welcome aboard. That was great. And we're going to have Chris back with maybe this cast, maybe a slightly different cast in 2 or 3 weeks to ask a completely different set of questions about what can you infer from models about directions for drug development, which I think is a fascinating question and kind of a lot more optimistic and open-spirited than this kind of discussion becomes. But Chris, thank you so much for that. Ian, thank you for providing context and at the beginning and staying throughout. And Jörn and Louise, great discussion. Everybody, thank you very much. I will be back in a few minutes with the business wrap-up. Until then, why don't everybody say goodbye, and then we'll go on.
Bye.
Bye.
Thank you, folks.
Goodbye.
Okay, bye-bye now.
And now for the Season 3, Episode 13 Business Report.
This will be the last episode we record in February 2022. For whatever reason, February listenership is always a bit light compared to other months. Last year, February had the FDA webcast on drug development, which is still our second biggest podcast and largest full episode ever, and the hashtag previews, and it still was our third smallest month of the year. That's not just because it's 28 days long. There's just something about the sequencing. This month, February brought in over 3,700 downloads, despite not having any major news stories or conferences to preview. It's our fifth biggest month ever, but enough of a drop from January that it felt a little bit slower, which is why I'm so happy to tell you everything we have coming in March.
The next 4 weeks offer some fantastic episodes.
The next 4 weeks include 3 sponsored extrasodes, maybe 4, a major conference wrap-up, an episode with Scott Friedman and the renowned Scottish researcher Neil Henderson discussing groundbreaking research, and, just for kicks, an episode exploring a whole new way to think about drug development targets. Let's start next week. Stephen will be back, and Quentin Anstey will join him to dive into details on the issue of balloon hepatocytes that got so much attention at NASH-TAG. This session will be sponsored by HistoIndex and will include a 30-minute extrasode at the back end where Mazen Noureddin and Dean Tai, the Chief Scientific Officer from HistoIndex and a co-author on the balloon hepatocyte paper, join Stephen, Quentin, and me to discuss ways to improve identification of balloon hepatocytes, both in patients with advanced fibrosis and separately cirrhosis, with Mazen discussing cirrhosis based on his poster of distinction from last year's AASLD meeting. The following week, Madrigal Pharmaceuticals will be sponsoring our wrap-up of the second annual Liver Connect conference with a cast of frontline key opinion leaders I will be announcing next week. The week after that, Chris Estes and Jörn Schattenberg return, this time with Stephen, to discuss what disease modeling and epidemiology can teach us about drug development strategy. Whole different way of thinking about the issue. And the week after that, the month will end with Drs. Friedman, Henderson, and Jonathan Epstein from the University of Pennsylvania discussing Dr. Epstein's extraordinary work linking CAR T cells to mRNA, the kind used in the COVID-19 vaccines to dissolve fibrosis. Stephen will be along for that one also. All 4 of these really should be can't miss for our listeners.
Coming later this spring.
We will have conference sponsorships and a new limited duration podcast series to announce for the next couple of weeks. Stay tuned to this section.
And in the vault this week.
The last few weeks have gotten good first week numbers and lots of happy reviews, but have not converted into a lot of vault activity. That's why the numbers are down. A few sets of episodes have gotten interest. The Splendor Study series, S3-E13, and The Conversations, which discuss the impact of bariatric surgery-induced weight loss on cirrhosis, and then S3-E1 on whether this is the time to pivot from biopsy towards NITs, S2-E57-1, which raises the same question in the context of papers presented at last year's AASLD, and S52.3 discussing how to make MRE a more robust trial endpoint for NITs. Anybody sense a common theme? Before we go, I want to say a couple more words about Ukraine. It had been my hope that we could actually speak in Ukrainian in solidarity with our Ukrainian brothers and sisters a couple of times on this podcast, but I've been unable to find anybody on quick notice who can translate Ukrainian for me and translate English into Ukrainian for me and then coach me on how to get the dialect right. If you're listening and you would like to help, we'd love to do that for the conversations or for next week's episodes or whenever appropriate, depending on how the war goes on there. Please contact me at questions@surfingnash.com. Let me know you're here out there and you're interested, and we'll arrange to talk and see what we can do. Thanks. So with that, I want to end by thanking our team, Magic Mike, Eric, Steve, and Gene, who will heretofore be known as Murph the Magnificent, for our continued success as we push forward into larger audiences and new frontiers. As I say, more on that in the next few weeks. And with that, I'm off. Stay safe, surf on. I'll look forward to seeing you all next week on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.